And so where do you put just some of the recent trial publications? First, maybe VISION. Where do you, how does that impact or influence how you practice?
So I think, after FDA approval with the VISION trial, we were seeing a lot of patients with really no treatment options left. And we are starting to see many more patients who have only had one taxane and one NHT. And so it is, I think that we are offering most of those patients radioligand therapy, presuming that they meet the criteria from labs and imaging standpoint. We do talk about all options. We talk about chemotherapy second line. We talk about second line NHT. And I do think, especially for people who have not seen two NHTs, the discussion of combination versus lutetium monotherapy is one that's still unanswered a little bit.
Right.
And so when we looked at our single center study, we found that only 10% of people had combination therapy, whereas in the VISION trial, about 52% had combination. So it's definitely, I think, an interesting question to be answered long term. Is lutetium to be used ideally in combination or as monotherapy? And I don't think we have a concrete answer on that.
We don't. And Yoey, you had mentioned kind of earlier just that there are settings where it is post-hormonal agent doublet and non-taxane. And so I know there have been some trials that have published there in that space. And how do you contextualize that and use that in your clinical decision making?
Yeah, no, that's a great question. So I think you're talking about the PSMAfore study investigating the lutetium prior to taxane-based chemotherapy, but for patients with prior ARSI treatments, and the result was positive. And in terms of radio progression-free survival benefit, there were a fair amount of crossover, so that we didn't really see OS benefit for that. But in that regard, I think the field is moving to that direction, moving up lutetium or radioligand therapy upfront. In my clinical practice, if I see a patient who already got RSI, who already got paclitaxel, the next line treatment I probably will consider lutetium over paclitaxel. And the reason for that is sometimes, again, the patient's kind of like sick and tired from the chemotherapy treatments. We have quality of life data that lutetium is much tolerable compared to systemic chemotherapy. And the dosing scheduling is also a little bit better compared to every 3 weeks dosing chemotherapy. So I would take lutetium upfront, prioritize that before paclitaxel, and that is pretty much now the standard care if I offer to the patients now.
Right, that's a great point, because I think that is speaking to the shared decision making with taking care of patients. And we have data, and we have trial publications and presentations, and then you have there in the exam room the patient in front of you, where you're eyeball to eyeball, and I think you've really spoken to that. And I think the real world evidence has also given us a little bit of guidance, as well as your center review. And how do you contextualize that?
Yeah, I think that to the point that you're sitting there with the patient, I think we have supportive data now to say, okay, I understand the regulatory bodies are wanting to look at overall survival, and both the SPLASH trial, which just presented at ESMO, PSMAfore, both studied in the context of prior to taxane use, both supportive in improving radiographic progression-free survival, but both had crossover, so the OS data actually was above 1, and thus we haven't seen that approval yet. But you're sitting in front of the patient, and I have some patients who just say, I'm never gonna do chemotherapy, I won't do it. Or it is someone who's frail and maybe you're worried can't tolerate that therapy, and this is an easier therapy to tolerate. And so, I mean, I have used it. I think we have at our center in those instances, frail patient or just patient denial of chemotherapy, and we certainly see benefit. So I'm hoping in coming months that we'll continue to see follow-up on these couple trials that have tested it prior to taxane use, and some approval or indication there.
Yes, because I know that we have shared patients who are in the pre-chemo setting who had they graciously declined the kind offer of chemotherapies, is the way I like to put it, because there is going to be that group, and I as well look forward to some, I guess, regulatory guidance in that perspective. Yeah, go ahead.
Oh, I was just going to say, I really think there's tremendous enthusiasm for radioligands with patients. And even in the hormone-sensitive space, I have patients walk in the door asking, get me the radioligand therapy. I'm ready for it. And so, I think that the hormone-sensitive trials are very exciting. And, I think that the PSMA addition, as it reads out, will be very impactful in the field. And so I think that radioligand therapies will be moving earlier. And, I think, of course, there will be people that don't have it early in disease because of access issues, and they'll probably get it in very late disease. So we'll see it across the entire spectrum.